I think we're going to get started. And our final topic is optimizing precision in comprehensive annual chest CT imaging. And to do this, I am co-moderating with Carolyn Aldigé. I'm Jim Mulshine again, thoracic medical oncologist at Rush.
Good afternoon. I'm Carolyn Aldigé from the Prevent Cancer Foundation, also known as BO. So you may hear me referred to like that, but I'm delighted to be here. Thank you.
And we now have the pleasure of introducing our panelists. Do you want to briefly introduce yourselves? Oh, gotcha.
So, hi, Rick Avila. I lead Acumetry.
Matt Cham, cardiothoracic radiologist, University of Washington, Seattle.
Hi, I'm Fain. I'm a professor of radiology, biomedical engineering, and electrical and computer engineering at University of Iowa. And I've worked for over 20 years now in various aspects of pulmonary imaging.
I'm Jan Gratama, thoracic radiologist in Gelre Hospitals in the center of the Netherlands, teaching hospital. And I'm involved in foreign lung cancer screening project.
Thank you. Matthias Oudkerk will join us presently. And one of the things that we wanted to talk about in this setting was we've heard about, the different efforts in different countries and the very important efforts from the analyst team, from Nelson and from I-ELCAP. And the question is, are there areas that are maturing that allow us to think about standardization, harmonization, collaboration in a more productive way? And Rick, you had some slides on AI quantitation. Does any of that helpful?
Well, I mean, I presented earlier on calibration phantoms, and we discussed table phantoms and many other things. So I think I covered that already.
Okay. So there's a wealth of experience that's been building up that we've been hearing about in terms of moving from just chest evaluation for lung cancer to chest evaluation for cardiovascular disease, as well as for emphysema. Is there things that we might want to think about? And I'll run through all the sentiments from the panel in terms of opportunities to collaborate, to standardize, to kind of come together on structure, on reporting, on data elements. We heard about what they've done with I-ELCAP in terms of a data dictionary. Are there some more opportunities in this regard that we should be thinking about as this field kind of moves into its adolescence? Rick, want to start?
Well, I mean, so the title is Optimizing Precision. And I always think of it as precision and bias. So in terms of measuring small lung nodules and that type of thing, or quantitative.
Can you define bias for the mere mortals?
So David wants a full description, I can see. So what I'm referring to is that precision is regarding if you take a measurement numerous times, for example, what's the standard deviation of that measurement? And the bias is how much does the mean differ from what you know is ground truth, whatever the value was supposed to be. So the truth is that when we do lung cancer screening and we're measuring small lung nodules, it's both the precision and the bias that matter. I think we have to, in general, make sure that when we report out our algorithm results and other things, that we're also reporting both precision and bias. And that's just one aspect that I think will help improve our ability to assess the quality of different tools and methods.
Thank you.
How are you gonna measure bias? You don't know what the true size is ever.
These.
It's,
So I'll pass around some 3D printed objects. Thank you, Claudia. I was hoping somebody would say that. So yes, real lung nodules we don't know the size of, but we can take a real scan and we can 3D print basically that object and send it around and put it inside of calibration phantoms all around the world. So I'm going to send you two objects. It's going to pass around. One object is a real lung cancer detected in CT lung cancer screening. It's about 9 millimeters, I think, in diameter. And the other object is a purely geometric object. It's a 6 by 3.6 by 3.6 millimeter ellipsoid. You'll see it often in the Kiva small lung nodule profile document. And it also has what we kind of call spiculations. And those look like cones sticking out of it. So those are about 8 millimeters. So the problem is that to see the features of that object is extremely difficult with current CT scanning technology. And you'll often lose the spiculations. You'll lose a lot of the size of the nodule itself. And it's extremely hard to make these objects, the spiculated one in particular, but they're very useful for assessing both the bias and precision of CT scanning, imaging, and software algorithms combined.
So this falls into the general realm of metrology.
Yes.
And the effort that we made to try to make metrology more accessible to the evolution of scanning was the effort sponsored by Kiva, by RSNA, called Kiva, the Quantitative Imaging Biomarker Alliance. And, you know, some of our panelists have been very intimately involved in that. Kiva is transitioning. And one of the things that we wanted to do was to continue with that effort in a format that is helpful to the evolution of chest screening as it moves to this broader imaging goal. And so the metrology effort, fortunately, we have the support of American Lung Association to continue our committee in doing this with regular participation, actually internationally. And we welcome, you know, anybody who wants to join us on our monthly calls to wrap their arms around these problems. Rick, did you want to make any comments about the frontier in terms of the things that we still might go after beyond you've talked about the phantoms, but there's other issues that, you know, like with the integration of emphysema imaging with lung cancer imaging from a technical perspective. Do you want to comment on that effort?
Sure. So you've probably seen multiple groups here talk about creating a protocol that will be good for not just lung nodules, it'll be good for emphysema and also cardiac. And technically, to make that work for all, let's say, the current scanner fleet, or most of it, 99% of it, is a non-trivial task. The reason why, what's that? Sorry, to say the least. So the reason why is because let's take lung nodules, for example. Lung nodules, we'll start with solid lung nodules in the range of 4 to 10 millimeters. They have very high contrast. They typically have very high contrast with respect to the lung parenchyma that usually surrounds them. So noise is not a big issue usually. We don't see failures generally with solid lung nodules due to noise. But with emphysema, noise is a huge issue. So a bulla or a pocket of air will be minus 1,000. Background lung parenchyma is minus 850 in a healthy person and minus 900 or more, or less, I should say, in somebody who has, let's say, lung disease of some type. So the contrast is much lower.
Inspiration.
What's that?
And then poor inspiration.
And for inspiration, yeah. And so the problem is that the noise, your signal to noise and seeing the boundary of an emphysema pocket, if I could call it that, is much worse than for a solid lung nodule. So it turns out that when you want to optimize a protocol that handles both of these, small lung nodules and emphysema, you're actually needing different resolution. If you go back to what I said earlier yesterday, I think it was, the resolution and noise basically are a trade-off. And so what we wind up doing is we wind up creating a protocol that's somewhere in between. Basically, we'll get the highest resolution we can, and then we'll process the data. You'll create like 3 millimeter slices, right? Or 2 millimeter slices to do emphysema measurement. Is that
No,
right?
no, we have 5 different reconstruction protocols afterwards. So we do separate for nodule, emphysema, calcium, for cardiac, all different protocols.
Right.
Yeah.
So where I'm going with this is that on one end, we have very high resolution and we can tolerate lots of noise. And on the other hand, we have emphysema, which doesn't need such high resolution usually, and can't tolerate much noise at all. So where we're headed, it appears, is we're going to collect still very high resolution data, but we're going to reconstruct it in different
Exactly.
ways.
Yeah.
And that might not just be a scanner reconstruction, that might also be a post-processing reconstruction, or not reconstruction, rebinning of the data. But we might also have additional reconstructions we'll need for other diseases, other things that we need. And I think what's going to wind up happening is we're just going to have multiple series for different clinical measurements.
Now we will get reconstruction algorithms per imaging biomarker.
Yeah.
And that still has to be developed, but it's already going the direction. For example, you cannot use any iterative reconstruction for calcium scoring. So the calcium score will dramatically go down with iterative construction. You cannot apply any value that has been established in all the evidence that there is there. So you have to also comply what we did in all the studies, that the results that we have of EBT as the best methodology in terms of temporal resolution combined to spatial, we translated that to the applications with dual source systems, first, second, and third generation. Mm-hmm. And just to bring that over, you can use the evidence of EBT and translate it to the current evidence. Till we have now, so we have also proven that it works, that you can translate the third generation dual source systems, ECD triggered. So second generation ECD triggered to third generation not ECD triggered.
Yeah.
But you have to prove it.
Yeah.
So we have proven all those steps. So from EBT, first generation dual source, from to second generation dual source to third generation non-triggered, as we showed here, very heart rhythm insensitive, but at the same time, you will have around 3-4% that is not optimal. So that is something you have to accept.
Yeah.
And what we showed also here, that if you look to the comparisons, so we did it in altogether now in a few thousand, and that's a huge, that you can do it so good without any correction in heart rhythm, no beta blockers, no ECD triggering within interval of 3 months is amazing, I think. But at the same time, AI also comes in. So you do the automated AI on the reconstruction of the calcium score. And then you think automatically that the heart rhythm will be the spoiler. But then you find that the AI did not do the right anatomical identification. And that is probably more the reason than the acquisition.
Mhm.
So that all has to be figured out.
Yes. So these are complex issues. And so what we're trying to do now is to take the work with lung nodules, infuse it with the density profile that Sean and colleagues developed. And I had the privilege of working on this with Kyle Myers and with Artit Birnpatnakal. And now we're going to transition. Kyle's got going to stay with us, but we've asked Sean, who is co-chair of the successful density profile development, to join us so that we can get the kind of technical issues that Matthias just described, the equivalent on the density side, married to the optimal acquisitions that we can do for lung nodule characterization. I can jump out of order just real quickly. Sean, any comments in that regard?
Yeah, I'm slightly more optimistic than Rick, I think. Yes. So in our profile, we inherently designed the profile to also allow high resolution imaging of the airways. So there was both the quantitative density aspect, but also in the back pocket, we were always thinking we wanted to quantify wall thickness and lumen area. So while it's a challenge, I agree, for the same reasons that Rick outlined in terms of noise, it is possible to balance both accurate density measurements and high resolution. In our profile, we were confined to a smooth kernel, and the idea behind it was not to do multiple recons. But if you do go that direction, you can further optimize your approach to amplify the spatial resolution for the purposes of the nodule volume measurement, and then use a smoother kernel for the quantification of the parenchymal density. And I like that approach a lot. I think that's probably a great way to go. There are some things, though, from the point of view of quantification of emphysema that I think are absolutely critical, that may or may not be well controlled in the current lung cancer screening approach. The most important source of variability is inflation state of the lung. And so if coaching is not being done in a consistent way to achieve the breath hold, then you're going to get a lot of variability. There are ways to try to correct for that post-processing, like doing a density correction based on lung volume and a constant mass and things like that. They're not optimal. So it's much better to prospectively generate a coaching paradigm that's consistently used. The other issue, as you outlined already, is kernel selection, right? So if you're varying the kernel that you're using for reconstruction, the kernels that are higher frequency will amplify noise and radically change the volume of the lung that's considered with the semitis. So controlling the kernel to be consistent as best as possible across vendor makes and models is also important.
Yeah. So I think the idea of coaching has come up time and time again. And we tried to cover it in our profile with the methodology that had been worked out at WashU. And it's one of those things where getting that right helps us so much downstream that this group might want to think about putting together some kind of YouTube video or whatever that would be available internationally to kind of try to standardize that aspect of things. And there's no technical commercial value really, but it's foundational to quality. So, this is one of the things that we could work together on, because we don't want to have 100 people kind of doing the best they could, whereas we could do it once and share it with those 100 people. So let's keep going. Matt, Sean, were you finished?
Yeah, that's fine.
Thank you. Thank you very much. Matt, any comments?
Sure. Yeah, the one thing that comes to mind in terms of optimizing precision is in coronary calcium scores. So as you know, we routinely evaluate those on lung cancer screening CTs these days. There are more software packages now that will measure them from full field of view CT scans. Whether or not they will succeed with low dose environments like 0.7 millisieverts remains a question. I think many of them will succeed at the 1.5 millisievert cutoff, but if you drop them below 1 millisievert, they probably will fail, many of them. And one of the key things is that these software packages have, publications that back up their reliability or accuracy, but then again, each software package is tested on a completely different patient population. So ideally, you want the packages to be tested from a common database. So it's almost like a shootout where you want to know which package is better, but there's no way to test that. So for example, at our institution, we're deciding which, coronary calcium scoring software to use. And we just have to base it on which is easiest for IT to install, not based on which one has the better quality. It's completely a broken system in that regard. We're not using the best software. We're using the one that's most convenient for IT to install, is what our threshold is, which is not very high. Do you have a question, David?
Well, I was just sort of confused by that. But you don't know, do you know which one is best?
We don't know. So a lot of the packages now, they're incredible because they do all the analysis in the background. So instead of opening the images, reviewing it, or analyzing it in real time, you click on the name and the results are there. Essentially, instead of taking 2 minutes, it takes a fraction of a second to get the results. They're often injected on your dictation system. And presumably, when you use these software, you're not going to retest it. In other words, if it tells you the score is 500, you're going to assume it's right. You're not going to measure it yourself, because what's the point? If you measure it yourself and you realize, oh, it's really 400, not 500, why would you remeasure it if the software already did it for you? Just like if the AI software tells you that nodule is 4 millimeter, you're not going to remeasure every nodule to make sure they're really all 4 millimeters. You're just going to assume they're right. That's the purpose of the software. So it's very tricky in that regard if you rely on these software packages.
Okay, thank you.
Is it showing you the product of what it's producing, or is it just giving you the answer?
You can review the product as well. So you can review that if you want to.
Okay. Matthias, any additional thoughts on opportunities for
Now,
conversations?
yeah, the noise in emphysema is a major problem. And I think one of the major problems there is what we call random, and I'm very curious what you think about it, that if you are at an available level, so down the 100 cubic millimeter, you really come, so that's also smaller than 6 millimeters. You really come into an area where you encounter in what we think is random noise clustering. So, and this noise clustering can really mimic early alveolar emphysema development. And that is that we could, in a certain region, probably hypothesize for further research that we say, okay, when we want to get rid of this random noise clustering, we would like to have a threshold where this is not happening anymore. So then you are referring to size. And we know, of course, it's also extremely sensitive to the threshold of, so in the literature, you have applications from minus 950 to minus 960, something like that. But if you go down in the literature, then the threshold of minus 950 goes down even before the Hounsfield units. So that comes from the era that we had still EMI units in 1982. And there you find the first, it's more, there they even try to make a kind of relationship with histology. And then they came to more or less a proposal that it should be somewhere around the minus 950. Then 475, because it was half, the EMI units are half Hounsfield units. So minus 475. Then you get a new, in 1996, a real good effort to come to a further, determination what is the best threshold, and then they take over the minus 950. So exactly the same, but it's still a proposal. And then you see in the, that there is no further research anymore, because at the moment, if you want to do histology, so the lung is out and it collapses. So there is no true state. Histology is not really a comparison. So you have a very strange situation that even if you have the resected lung with the emphysema, bullae and everything in it, you cannot compare it with the imaging. So the imaging itself is its own gold standard,
Yes,
more or less.
so
So
ground
what
truth,
we could
yes.
also do in the selected, selected population, and that is something that we could do in a collaborative effort, that we do a dose study. So we look to emphysema at high doses, and then we go down to low doses, and then have a look how that changes, and if there is a threshold of measurement that we could rely on, or a correction, or that kind of stuff. Now, another way to go would be that we say, okay, we follow the hypothesis that because we want early detection of emphysema, and if you look to the interrelationship between readers, then they agree when it is getting more, but they don't agree when it is early. So that is, and then you get major differences. And in our studies where we compare the readers, you find that at -1,000, the reader agreement is the best at -1,000, because you get rid of all the noise. And then they agree the most on the images. So it's all explainable, but you lose everything that has to do with emphysema when you go down to -1,000. So it's that complex. So a way to go could be that we try to get rid of the random noise clustering, and then we hypothesize a threshold of the acinus level, which is 100 cubic millimeter, and that everything that is lower, we hypothesize that it is mainly due to random noise clustering and not to emphysema. And then have a look if we can come to a better reader agreement if we do this, then we get at the current moment with -1,000. So we did also comparison, and then that really showed how very sensitive it is between -975, -70, -960, -950, and -25. The difference in the low attenuation areas is huge. It's really huge, extremely sensitive. So there are now 6 papers over the last 15 years where you can find that the emphysema threshold is different, and it's on -960. In our readers, if we do the comparison, tend to go to the threshold of -960. Now, most of us would say, well, what the heck, what is the difference between -950 and -960? In emphysema, it's all the difference. So that kind of stuff has to be really resolved before we go further.
Okay, well, that sounds like a very important thing that we can dig into.
Couple of thoughts can I add to that? So I agree with almost everything you said.
Oh, that's
It's true that 950 is a very antiquated threshold, and it basically found purchase because of that paper comparing to histology. And it was, resected lung that they were identifying. And there's no reason why -950 is magic, and to explore other thresholds makes sense. To say that there isn't any research in this, just I want to comment on a couple things, that there are a number of different efforts that are trying to get away from the histogram-based approach, looking at multiple inflation states. So the downside is you don't typically acquire a functional residual capacity or an RV volume, but studies I'm involved with in COPD gene and severe asthma research program, we're acquiring both an FRC or an RV and the TLC lung volumes. And we can do a deformable mapping of the 2 volumes to determine the change in Hounsfield units. And that is a much more robust approach that's not as sensitive to the norm. Now, the other solution to this could be that, first of all, I think the clustering you're talking about is real, because the noise in CT images is correlated, right? So it's not a purely random noise process. And that means that there's going to be spatial dependence in the noise that probably reflects the clusters you're talking about. So there's a number of approaches trying to model that noise using the noise power distribution to help correct for that. Probably the most, in my hands recently, in terms of developing harmonized protocols for PRECISE, which is an extension of the Severe Asthma Research Program, we were able to get reasonably good performance with model-based IR techniques that helped mitigate some of that noise. And I was curious, in the data you showed for the coronary artery calcium, you were seemingly showing that IR was magnifying or amplifying the Hounsfield units in those regions. And at the low end, it doesn't seem to be doing that. So I was just curious, because we're not caring, in my world, I'm not caring about the upper end, I'm caring about the lower end. So it's curious that IR is driving in different directions, maybe.
Okay, so let's continue this offline. Let's keep moving on the
All right,
panel.
sorry.
Because this is a pretty deep dive. Dr. Grush, any additional comments for opportunities for harmonization, standardization that you would care to discuss?
Me?
Dr.
Gratama.
No, also some worries on the low attenuation, but on the coaching of the clients to increase it. But I think this subject has been more than adequately covered by the previous speakers.
Oh, okay.
Maybe I was also thinking of maybe increasing the dose to reduce the noise. But I think that with the newer scanners, that shouldn't be a problem.
Okay. Okay. Thank you. Thank you very much. So this is all critically important. We'll follow up on it. But one aspect of this international workshop meeting is that we have this opportunity to screen the chest, look at these disease sites of major, morbidity and mortality outcomes. And yet the number of people that are aware that this is emerging is extraordinarily limited. And so participation in our studies, willingness to donate data, willingness to participate in the refinement and development of AI tools, it's kind of background noise. It's an aspiration in our minds that's not shared more broadly. My co-chair on this is Carolyn Aldigé, who started the Prevent Cancer Foundation some years ago and has been all about the importance of communication in the prevention mission. Bo, having sat through this riveted last couple of days, is there anything you want to share with us in terms of communicating this back to the general public as a gateway to a more comprehensive prevention approach?
Well, I would say, yes, it has been riveting. And I'd also say that all we've been talking about for the past 2 days, refining screening, refining imaging, making it more precise, making it more perfect. Doesn't matter if people don't go get themselves screened. So I've been thinking about a few things in terms of the public communication aspect of it. Because I'd say even though the advocacy community we're here, but not in great numbers. Our job is to educate the public and to motivate them to do the kinds of things that we know will reduce their risk of developing lethal diseases and potentially lethal diseases. And one thing that came through to me really loud and clear, actually during Mort's presentation today, is let's get the word cancer out of there, out of the screening. Let's take out that word. Let's call it heart and lung screening if we possibly can. I don't know if we can shift the conversation, but I think it would be such a good idea because there is so much stigma around lung cancer. And there is so much stigma around lung cancer screening because it's just immediately people make the leap. Oh, well, you smoked, so go get screened. And if you have lung cancer, well, you brought it on yourself. So I think what I'd love to start the conversation is how do we move our audience, which is the general public and policymakers as well, to shift the conversation so that we can start talking more positively and the messaging becomes more positive about getting people screened. And I think we have a lot of lessons to learn from the breast cancer community. There was stigma around breast cancer when we first started the foundation in the late 80s. It wasn't something you talked about, and it was a stigmatized disease. And they've been able to move away from it. So how do we apply those lessons? How do we apply the lessons we've learned in colorectal cancer, which was another sort of verboten topic for a long time until we started sort of moving the needle on that in the early part of this century. And then finally, how can we shift the focus so that what we do applies equally to everyone? The disparity issue is hugely important to us and to most organizations, and I would argue to everybody in this room. But we've got to do a better job of addressing it. So that's a lot of questions. I'm throwing it open to the panel and to everyone. And Jim, if you want to, you'd like to take the microphone back and keep the conversation going?
No, we'll keep the conversation going. I think it's incredibly important, and it's not been a big emphasis. But like, to me, sometimes I sit in some of these sessions and I try to figure out how many terms the public would understand of what we're discussing. And it's it's a language that Tolkien developed for his children's amusement or whatever. But any comments from panelists in terms of ideas about how do we get these messages out in a more positive, productive way? And if not, from our participants, any thoughts? Mary Ellen, don't smile too broadly. Yes, Mort. Oh, I'm sorry. First, yes.
Well, first of all, I couldn't agree with Carolyn more. One of the examples of changing the vernacular is something that we've been involved with in the NHS's lung cancer. It's not really a lung cancer screening program at all. They call it a targeted lung health check. So they've already changed the vernacular, and the uptake of this program is 60 to 70% in some areas, much better to reduce some of that stigma. And some of the outreach, I think, has also been very valuable lesson in learning. And as prostate, although prostate screening is not being rolled out formally as a screening program in the UK, there's a large trial with 100,000 men that's getting kicked off. And the company also that we provide the screening or imaging support for is using that same vernacular. So it's going to be called targeted prostate health check, again, to try and remove the stigma. So I think that's a great comment. But my other point was, again, learning from the breast cancer screening community. Digital breast tomosynthesis was a new technology that was introduced over 15 years ago. The US is the only country that adopted it as a first-line screening tool for lots of reasons. It's eventually going to be adopted globally, but it's taking time. But one of the main reasons behind that, having worked for GE Healthcare at the time and watching the tsunami of this, it was the patient advocacy groups that got the new technology going, and going back to even the origins of breast cancer screening too, what Carolyn's referring to. So I would agree that we need to figure out how do we galvanize the patient community in a more cohesive way, like Susan Komen did with breast cancer screening and DBT being adopted. We're seeing patients at RadNet being educated about AI and asking us for it. 40 to 50% of our patients are actually paying out of pocket to use have AI used. I know there's controversy behind that because of the disparity issue, but we are using that data to show the payers that these new technologies, with the evidence behind them, with the radiologists and the policymakers, actually do lead to adoption. And my challenge to the lung cancer community is to be thinking about these mechanisms and how do we galvanize them in the same way.
Thank you. Mort, do you want to comment?
If I don't have to wait for the microphone.
You're actually doing a pretty good job.
Yeah. On mine. I would like to add to what
Caroline referred to as the stigma. I actually got the idea from speaking with Karen, the International Study of Lung Cancer Group, I-ELCAP. I'm trying to catch up with the terminology. That she said, we tried everything. We tried to reach out to celebrities who are influential, but nobody wants to stand up and say, I'm a smoker and I go get lung cancer screening. So I mentioned that this is why heart-lung is a good cover. And plus, we need to make it very easy for them. It has to be easy for them and also private. So if you download an app, you answer a few questions and you schedule your scan and you go get a scan and out and results is on your face. There's nobody involved here. It's just you and the care provider. So privacy, convenience, accessibility, and speed, I think can break finally the barrier that she is referring to. And I have an example, a simple example. You guys all go back to 2000 when Viagra came. You know, all these guys, you know, friends called, can you prescribe Viagra? And it was hard for them to get, for male to get. But once this online Viagra order became available, it just became a massive success. They would answer questions online in private, and they would get it in private. You know, that's kind of a stigma that men didn't want to be known that they're, you know, using these drugs. That's just part of the example. The same thing with HIV. We can learn from HIV. It was, as you know, 80% HIV was detected through symptoms. It's now below 20%. So there are success stories that we can learn from, and hopefully, you know, in 10 years, we'll be sitting here and we say we brought it down from 90% to 30%, 20%. The rest of them are all diagnosed through screening.
Okay, thank you very much. Thank you. Fred, I think it's the last comment.
Just to go to the issue of underserved and stigma. You know, it's like Viagra. Men who need Viagra can get it, but young women who need birth control can't get it. So that's a stigma. That's an underserved group. But the same is true of lung cancer in non-smokers. 20% in the United States and 60% in Taiwan, and yet those people don't get screened. That's an issue of social justice. That's an issue of perhaps ethics. And how do we deal with that stigma of refusing to screen those people who are going to die who've never smoked?
I don't think anybody refuses them to get imaging services. It's reimbursement that they don't get. And, but I take your point. I take your point. Okay. It seems like we have a bus on fire. I want to thank all the panelists, all the participants, and my co-chair